Welcome to AETCM, the Emergency Medicine channel. As part of EM Rapid 2024, myself, Dr. Pretty Matthews, first year PG resident, will be briefing you about post cardiac arrest syndrome. Sudden cardiac arrest represents one of the most time-sensitive diseases in the practice of emergency medicine, requiring prompt recognition and rapid delivery of resuscitative care, including high-quality CPR, early defibrillation when appropriate, and appropriate airway management. Even with these interventions, aggregate survival to hospital discharge is less than 20% in the most communities and hospital systems. Among the survivors, neurological injury is common, that it is present in up to 50% of the survivors and widely varied, ranging from subtle memory deficits to persistent vegetative state. Coming to the pathophysiology of post-resuscitation syndrome, the brain is exquisitely sensitive to ischemia, such that disruption of any blood flow for several minutes is sufficient enough to initiate a set of injury mechanisms that may lead to irreversible disabilities. The complete loss of blood flow, followed by the abrupt return of the spontaneous circulation, rapidly leads to a complex pathophysiological process known as ischemia reperfusion injury. And this ischemia reperfusion injury is also known specifically in the sudden cardiac arrest setting as post-resuscitation syndrome. Coming to the pathophysiology at the cellular level, mitochondrial integrity and functions become damaged, and this causes release of the crucial enzymatic machinery, such as the cytochrome C, and there will also be disruption of the oxidative phosphorylation. Mitochondrial injury is implicated in the increased concentration of the oxygen-free radicals, and there will be downstream activation of the programmed cell death pathways. At the humoral level, reperfusion triggers a broad array of immune activation, including increased blood levels of cytokines such as the interleukin-6 and the tumor necrosis factor alpha. In addition, aberrant neutrophil and platelet activation can also occur. These immune phenomena have led to describe the post-resuscitation condition as a sepsis-like syndrome because in sepsis, there is inflammation will be playing a crucial role in injury. And here also, since there is an increased production of cytokines and interleukins and tumor necrosis factor, this can be also considered as a sepsis-like syndrome. Now, this is the basic pathophysiology happening in post-resuscitation syndrome. As you can see that during the ischemia phase, there will be a production of reactive oxygen species, also like inflammatory cascades such as what we have seen, the tumor necrosis factors and the interleukins. And there also will be mitochondrial dysfunction, which will be leading to the blood vessel instability, cell death, and brain swelling. The same thing happens when there is a sudden reperfusion to the cells also. So this is the most common pathophysiology of post-resuscitation syndrome. Now coming to the pathophysiology at the organ system level, immune activation in turn can lead to the additional production of oxygen-free radicals such as the superoxide and the hydrogen peroxide. These molecules produced in the small quantities during the normal cellular function are usually converted to oxygen and water by the enzymes catalase and superoxide dismutase. However, enzyme systems become overwhelmed with a dramatic increase of the free radical species generated during the post-resuscitation syndrome. Different tissues exhibit varying sensitivity to ischemia reperfusion process, and brain tissue and the vascular endothelium appears to be particularly vulnerable to the ischemia reperfusion process. The biochemical and cellular phenomena leads to diverse clinical manifestation of injury in the minutes to hours following the resuscitation. Now coming to the clinical features that will be manifested in the patient will be, first and foremost, there can be hypotension, inflammatory changes, and the immune cellular activation can lead to vascular leak and a drop in the peripheral vascular resistance with concomitant loss of fluid from the intravascular compartment, and it may cause hypotension in the patient. The second most manifestation would be cerebral edema. Cellular injury in the brain combined with the endothelial damage can trigger cerebral edema, which is the most common and dangerous component of the post-resuscitation syndrome. Cerebral edema and the increased intracranial pressure can cause cerebral herniation and serve as the cause of death, and often it happens in the initial 72 hours following the resuscitation. The third most common manifestation is the myocardial stunning. Myocardial stunning is clinically evident on the echocardiography as global hypokinesis and markedly reduced ejection fraction. Myocardial depression is usually transient and typically resolves over the first few days following resuscitation with appropriate hemodynamic support. And also, at last, post-resuscitation infection may be related to the bacterial translocation into the bloodstream from loss of the intestinal tissue integrity. Following the initial resuscitation, the clinical condition of the patient varies considerably. Some patients with prompt recovery after only brief periods of CPR can be awake and responsive. However, most patients are initially comatose or markedly abandoned following the resuscitation. Neurological assessment is limited in the most cases because in the course of clinical resuscitation care, patients are intubated and sedated. Physical examination is limited in the immediate post-resuscitation, and most patients will be exhibiting absent or abnormal papillary responses, and gag reflex or Doll's-eye response also will be absent in patients. Clinical neurological reflexes are not predictive of cardiac arrest outcomes. International Resuscitation Guidelines strongly recommends that bedside neurological examination should not influence the decision for the continued care in the first 72 hours. Now, coming to the clinical signs, it focuses the physical examination after resuscitation on identifying clues such as if there is an asymmetrical lower extremity edema, it can suggest that there can be a thromboembolic disease. If the lung sounds are absent or decreased, it might implicate a pneumothorax. Jugular venous distension and muted heart sounds may suggest that the patient might have a cardiac tamponade. Promptly, we should obtain an ECG because myocardial ischemia is the most common cause of sudden cardiac arrest. Now, coming to the diagnostic test, neuroprognostication after sudden cardiac arrest is challenging and inexact process. A variety of radiographic, biochemical, and neurophysiological tools are available to assess brain injury following the cardiac arrest, but most are poorly validated and require additional research to determine the clinical utility. So, the most commonly used diagnostic test in the ED is the CT head. We can perform head CT in survivors as soon as feasible. Head CT can identify any subarachnoid hemorrhage or epidural or subdural hematomas. The degree of cerebral edema can also be assessed by the head CT because cerebral edema often peaks several days after the resuscitation. Swelling that is radiographically apparent on the initial CT is worrisome sign. Brain MRI is generally neither practical nor useful during the initial ED management. The early institution of continuous EEG monitoring to assess for electrical convulsive activity, which can be present in up to 25% of the patients after resuscitation. The presence of seizures generally gives a poor prognosis, but not all patients with electrical seizure activity sustain severe long-term injury. And also we can do the bispectral index monitoring, a simple approach to the electrical brain monitoring relative to the EEG, and it is very useful to predict the neurological outcome. Measurement of somatosensory evoked potentials, which is a bedside test of neuronal connectivity and function, can also be performed several days following the cardiac arrest and may also be useful to predict the outcome. So the most common test which we use during the post-resuscitation is we can go for a CT head, we can also go for an EEG, or we can go for a bispectral index monitoring, or a somatosensory evoked potential measurement can be also done in the patient. Coming to the management of post-cardiac resuscitation syndrome, it is mainly managed by the targeted temperature management. The key ED intervention for post-resuscitation syndrome is the prompt delivery of systematic cooling therapy, also called as the therapeutic hypothermia or the targeted temperature management. Systemic cooling of the resuscitated adult cardiac arrest for the 24 hours following the arrest and return of the spontaneous circulation can dramatically improve the survival and the neurological outcomes. A multi-center randomized European study demonstrated that therapeutic hypothermia instituted for the first 24 hours following the cardiac arrest and return of spontaneous circulation resulted in cerebral performance assessed. Some controversies also exist regarding the appropriate target temperature for post-cardiac arrest care. Most hospital protocols aim for a core temperature of 32 degrees to 34 degrees, that is 89.6 degree Fahrenheit to 93.2 degree Fahrenheit. Modest cooling to 36 degrees Celsius produces similar outcomes as cooling to 33 degrees, but there is still considerable debate about the best goal temperature for post-arrest target temperature management. The criteria for targeted temperature management is the inclusion criteria is that any patient after post-resuscitation and achievement of ROS and the GCS score is less than 6. And if there is no other reasons for coma, and if the patient is not having a DNR or DNI status, and if the patient is above 17 years, we can include in this criteria and go ahead with targeted temperature therapy. And the patients who are completely awake or alert after the cardiac arrest had a traumatic etiology which led to the arrest and has a significant bleeding which is associated with the arrest, or the patient was in coma or vegetative state prior to arrest, or patients who are pregnant or with the status of DNI DNR, those patients should be excluded from giving the targeted temperature therapy. And patients on warfarin or heparin, or patients with an initial arrest rhythm which was non-shockable, or patients with long QT syndrome. These three criteria is not an exclusion for the targeted temperature management. Now, as we can see, this is what we follow in the targeted temperature management. As soon as the patient gets arrested and ROSC is achieved, we plan for the cooling of the patient, and then we maintain that temperature. And when there is any concern for shivering, we go for the rewarming of the patient because it can cause hypotension in patient. So in those patients, we go for rewarming. The components of the cooling and the supportive care is, first we have to maintain the core body temperature between 32 degrees Celsius to 36 degrees Celsius, and it should be soon as possible, and it should be within 4 to 6 hours after the attainment of the ROS. So the surface cooling can be done by using ice packs or chilled saline to the axilla, neck and the groin. Cooling blankets, vest and leg wraps also can be given to the patient. Cooling helmets also can be given for surface cooling. Then coming to the intravascular cooling, 30 ml per kg normal saline at 4 degrees Celsius can be given as IV over 30 minutes to the patient. And if the patient requires, we can go ahead with the intubation and mechanical ventilation. And the patient's ECG, continuous cardiac monitoring, pulse rate, and ETCO2 must be monitoring throughout the management. Patients should be sedated and neuromuscular blockade should be given. Central venous and arterial access should be maintained. Continuous core temperature monitoring, that is using a bladder catheter or a central venous catheter or an esophageal probe, should be done. And we have to maintain a MAP more than 60 mmHg, and we have to check the electrolytes every 4 hours and maintain this hypothermia for next 12 to 24 hours, and never let the core temperature drop below 32 degrees Celsius. That is, we have to avoid fever in the patient. Coming to the complications of the targeted temperature management, the most common complications are the bradycardia. There can be prolongation of the QT interval, any coagulopathies with PTT prolongation, hypokalemia during the cooling or hyperkalemia during the rewarming, and it can also cause shivering in the patient. And the less common complications are there can be non-sustained ventricular tachycardias, there can be significant bleeding in the patient, there can be skin injury or ulceration from the surface pooling. Now, the special considerations while we go for targeted temperature therapy is in children, there is no special indication for targeted temperature management after cardiac arrest because there is no proven study that shows a benefit from lowering post-arrest temperature in children. In pro-hospital application also, some EMS systems have protocols to initiate cooling prior to the hospital arrival. Although these strategies has local validity, recent randomized trials found no improvement in outcomes and possibly a higher frequency of re-arrest with pre-hospital cold saline infusion. So current resuscitation guidelines do not recommend pre-hospital induction of targeted temperature. Many post-arrest patients should be considered for prompt cardiac catheterization given the likelihood of coronary occlusion, especially in the setting of ventricular fibrillation arrest in patients with coronary risk factors. So in those patients also, targeted temperature management can be continued safely. So with this, we come to the end of the topic of post-cardiac resuscitation and its management, that is the targeted temperature management. Hope you guys have understood. And the take-home message of this post-cardiac resuscitation syndrome would be how we manage in our emergency medicine room, how we follow up the patient after we attained the ROS. So the first and foremost thing is maintain a temperature between 32 to 36 degree. Continue sedation and neuromuscular blockade for the patient. We have to put a central venous and arterial access in the patient. We should always be continuously monitoring the core temperature of the patient. And we have to maintain a MAP more than of 60, and also every electrolytes, that is mainly the sodium, potassium, and all the other electrolytes also should be monitored, Q4H, and also we should prevent hypothermia. That should be always kept in the mind that even if we are going for a targeted temperature, we should never go for a hypothermia in the patient, and always the temperature should be more than 32 degrees Celsius, and also we should prevent fever in the patient. These things are the main highlights of this topic. Hope all of you have understood. Thank you.